So hello everyone, this is Dr. Vineet Sehgal and welcome to the image-based questions session 3. In image-based question session 1 and session 2, we talked about some important images that are there in the eyelid, that are there in the orbit, and we also talked about the important image-based questions like applanation tonometry, gonioscopy, and the fundus images in glaucoma. Today in the image-based questions session, I would be talking about the important images that can be asked and what are the relevant clinical scenarios in cornea. You can see all my lectures exclusively on the Unacademy app. If you want to go with the plus subscription, which have the added advantage of the daily life classes, structured schedule, live test, and the unlimited access, you can go with the plus subscription with my code, that is Ophtha10. You can also go with the iconic subscription where you would have the additional advantage of the prep ladder also. In the prep ladder, you would get a video lectures, question bank 2.0, and the rapid revision course. There is a limited time offer also where you would be getting the iconic subscription in never to see rates, which is just 58,500 for a 3-year subscription. If you want a 1-year subscription, that is also having a lots of discounts. With just 40,500, you can have the total package of the Unacademy with the prep ladder. Also, if you want to go with a 3-month subscription, you would have a 1 month extra free of cost. There are a lot of batch courses which are going on. Two important batch courses for the NEET PG aspirants and the FMG aspirants are the NEET PG Season 1 batch as well as the FMG Test and Analysis batch. Also, you can see 34,000 plus questions which are specifically designed for the PG entrance exam on the Unacademy Learning app. You can download the Unacademy app from the iStore and Play Store. Use my code OFTHEL10 to unlock the free platform and also use it for getting a discount. With this, I would be starting my session, that is the image-based questions in the cornea and the conjunctiva. So first of all, I would be showing you a picture of the eyeball. So in this picture, if you can see this area, okay, this is basically called a palpebral conjunctiva, okay, and this whitish area, this is sclera. So if this is my sclera, it is covered by my conjunctiva, okay. So remember, a sclera is covered by the conjunctiva, but then we have the cornea. So this area which you are seeing, this is a transparent structure which is cornea. Remember, the conjunctiva does not basically cover the cornea, okay. So bulbar conjunctiva is there on the sclera, but it is not covering the conjunctiva. Sorry, it is not covering the cornea. The junction of the bulbar conjunctiva and the sclera and the cornea is, this junction is called limbus, okay. So this is this area which you are seeing, this is called limbus. So these are the most important anatomical landmarks of the anterior segment. On this basis, we would be having a discussion of our further slides. So this is my first slide. In this slide, if you can see, there is a hazy type of cornea and you can see there is a opacity here. I have just marked it, this is a opacity. So on the basis of how deep is the opacity, we classify into nebular, macular and leucomatous opacity. This is a leucomatous opacity. You would ask me, sir, what is the leucomatous opacity? So if this is your cornea, okay, and if the opacity is basically covering more than half of the stroma, remember the stroma is the thickest layer of cornea. If it is covering more than half of the stroma, then this is a leucomatous opacity. From just a clinical picture, how you can say that this is a leucomatous opacity? So if this is a leucomatous opacity, you would not be able to see the iris which is underneath. So here you can see there is an iris color seen, but in this area you cannot see the iris which is underneath. So this is definitely a leucomatous corneal opacity. Remember, in a nebular corneal opacity, there is just a nebular haze over the cornea. You can see the iris details inside, okay. In the macular dystrophy also you can have a faint idea about the iris, but in the leucomatous opacity you cannot see a iris. Leukomatous opacity, this is more commonly when there is a trauma to the eye, or if there is a, let's say, a perforated corneal ulcer. In that case also, when it heals with the fibrosis, and you can have a leukomatous corneal opacity there. So this is a band shaped keratopathy. If you can see this whitish opacity in the center of the cornea, which is basically a horizontal opacity, this is called band shaped keratopathy. And why this occurs? Because of the deposition of calcium hydroxyapatite crystals in the Bowman's membrane. So just beneath the epithelium we have the Bowman's membrane, and the calcium hydroxyapatite crystals which are basically deposit can cause this opacity. Why there is a band shaped keratopathy? So I have discussed a lot about the band shaped keratopathy in numero uno in ophthalmology series. You can go back to the cornea section and see its causes, but just giving you a brief about this BSK, the band shaped keratopathy, that any condition of the eyeball which can basically attract the calcium crystals deposition can cause a band shaped keratopathy. Now where it can happen, let's say there is a chronic uveitis, okay, there is an end stage eye disease like a atrophic bulbi, like a phthisis bulbi, and if there is a post retinal detachment surgery, if you have done a vitreoretinal surgery and you have put a silicone oil in the vitreous cavity, sometimes a part of this silicone oil comes anteriorly also, and then it can also attract the calcium deposition. So these are some causes, some ocular causes of band-shaped keratopathy. You can also get a band-shaped keratopathy in some systemic causes as well, like sarcoidosis, chronic renal failure, hypercalcemias. So any condition which can basically cause increase in the calcium level in the body, that can also cause a band-shaped keratopathy. What is the treatment of band-shaped keratopathy? You have to just scrap the epithelium above, and then you have to put a EDTA solution. What EDTA solution does is it basically chelates the calcium crystals. So that can be a treatment option for band-shaped keratopathy. If it is not resolving, then what you can do is you can just do a superficial excision of the cornea also. We call it phototherapeutic keratectomy. Also, if it is much deeper, then you can go with a lamellar transplant also. So these are some important points that you have to remember regarding a band-shaped keratopathy. Then this is the next clinical picture. In this clinical picture, you can see there is a opacity in the center of cornea, and these popcorn type opacities, you are not seeing any vascularization, you are not seeing any inflammation here. So this central opacity, which is usually bilateral, and they are not associated with any inflammation or vascularization, they are telling you about a corneal dystrophy. So that is the difference between a corneal dystrophy and a opacity. A usual opacity which is there after a corneal ulcer or after trauma, it has signs of inflammation. A dystrophy does not have any sign of inflammation. The second thing which is important regarding the dystrophy is that it does not have any vascularization. So these popcorn-like opacities which you are seeing, this is basically seen in the granular dystrophy. One thing that you can appreciate in this picture is that the distance between the two opacities, okay, that is clear. So this means that this patient would definitely have blurring of vision, but the vision would not be very bad. Maybe 6/9, 6/12 vision. But if a patient of macular dystrophy comes to you, there would be a total haze of the cornea in the center, and then there are few more dense opacities. So what I want to tell you, that they can give you a picture and ask you the vision is 6/9. What is your diagnosis? Your diagnosis would be granular dystrophy. If they basically give you a similar type of appearance and there is a ground glass appearance of whole of the central cornea with nothing clear area, and the vision is, let's say, 1/60, finger counting close to face, then your answer would be more going towards the diagnosis of macular dystrophy. Okay, then this is also an important image, so many times asked. This is basically a pterygium. So if you can see here, this area, this is a fold of conjunctiva which is basically covering the, or which is encroaching the cornea. So this is basically a vascular ingrowth which is basically impinging the cornea and covering it. This is called pterygium. Remember, whenever there is a pterygium, this is basically a collagenous degeneration. This degeneration has caused the conjunctiva to go upwards towards the cornea. What it causes is it can basically pull the cornea and cause astigmatism. So sometimes they ask what is the most common cause of decrease in vision in a patient of pterygium. So your answer is not a corneal opacity. Yes, it is causing a corneal opacity, but as you can see, the pupil is not involved. So unless the pupil is wholly involved, the patient is not having difficulty in vision, but he may have blurring of vision because of the pull of the cornea by this pterygium, which can cause a astigmatism. So I write it here. The most common cause of decrease in vision in the patient of pterygium is astigmatism. You can see this is the head, the body and the tail of pterygium. Okay. Then this is the next clinical picture where you can see fine branches over the cornea. Okay. This is basically called pseudodendritic ulcer. I also call it seen in Herpes zoster ophthalmicus. Okay, so what is the difference between a pseudodendritic ulcer? So you can see fine branches, fine pattern like here and multiple pattern like here. This is called pseudodendritic ulcer. When you have a dendritic ulcer, it is more of a larger one and you have the terminal bulbs. These terminal bulbs basically harbor the virus cells. This is called dendritic ulcer. So do not confuse a dendritic ulcer with a pseudodendritic ulcer. The dendritic ulcer is seen in herpes simplex keratitis and the pseudodendritic ulcer is seen in herpes zoster ophthalmicus. Okay, then there is a clinical picture of penetrating keratoplasty being done. You can see this is the donor cornea. Okay, so this is the donor cornea and donor cornea is basically attached to the host cornea. So sometimes students ask me, sir, that whole cornea is removed? So no, the whole cornea is not removed of the host. The central opacified part is basically removed and we put a near clear cornea here and we basically put the 10-0 monofilament nylon sutures to anchor it. Okay, so if you can see, these are the non-absorbable 10-0 monofilament nylon sutures which are basically used to attach or hold the donor cornea with the host cornea. Okay, then this is a picture of a patient. Let's say they ask what is the ophthalmic manifestation that you can get in this patient. So first of all, this patient is having lots of crusts which you can see here. Only one side of the face is involved. This patient is suffering from herpes zoster. And as I told you, herpes zoster, you can have pseudodendritic ulcers. Okay, remember this herpes zoster can basically affect each and every part of the eye. Not only just it can involve the cornea and cause pseudodendritic ulcer, it can basically cause iritis, it can cause retinitis, it can cause the damage to the optic nerve. So every area of the eyeball is basically affected with the herpes zoster. They can sometimes ask which area is most resistant to the infection. So the most resistant to the infection, the area or the wall of the eyeball is sclera. Okay, then this is a clinical picture of Arcus senilis. If you can see in this picture, just in the peripheral cornea, you can see a whitish opacity. So this whitish opacity which you are seeing, let's say this image is of 65-year-old patient. So this whitish opacity that you are seeing, this is basically a lipid deposition. Okay, and this is called Arcus senilis. And if you can appreciate, there is a peripheral involvement. The central involvement is not there. So vision is normal. So remember, whenever your visual axis which involves the pupil, that is normal, you would not have a difficulty in vision. This is a corneal degeneration. Do not confuse a dystrophy with a degeneration. The dystrophy that I showed you is a corneal dystrophy, a granular dystrophy. It is affecting the center of the cornea. the arcus senilis, which is a lipid deposition which is there in the periphery. It is not affecting your center of the cornea. Also, it is not a opacity per se after a inflammation because it is having no vascularization. This is arcus senilis. Then sometimes they can ask you about this investigation. What is this investigation done? So if you can see some hexagonal squares, hexagonal structures which are here. These hexagonal structures are basically telling you about the endothelial count. Remember, the endothelium of the cornea is its most vital structure. Why the endothelium is most vital structure? Because these are the powerhouse or the kitchen of the cell. They have all the anion and cation pumps, and also they make the eyeball, the cornea, as a dehydrated structure. So the transparency of cornea is basically there because of the endothelium. So if the endothelium is deranged, let's say after a uveitis or with age or after an intraocular surgery or after an endothelial dystrophy like a Fuchs dystrophy or congenital hereditary endothelial dystrophy, then this specular microscopy can tell you what is the specular count or what is the endothelial count. So not only it tells you about the quantitative analysis, it also tells you about the qualitative analysis. So how many cells are of their perfect shape, how many cells are not of the perfect shape, this can also be told by the specular microscopy. Then this is a procedure of Lasik going on. So remember, Lasik, that is the laser assisted in situ keratomylosis, where what you do is you change the shape of the cornea. You make it more steep or more flat so that the refractive error is basically taken care of. This is a Lasik surgery. Okay, Lasik surgery is of many types now. Earlier it was the conventional Lasik surgery where we used to take a microkeratom blade and used to cut the corneal flap and then use the excimer laser. Now to cut the corneal flap we have also the femto laser. Okay, so that is called eye Lasik. There is a conventional Lasik which is cutting the cornea, the flap of the cornea with the help of a blade, a steel blade, we call it microkeratom. Now we have the eye Lasik where we cut the flap also with the help of a femto laser. Then there is another type of Lasik which does not basically involve also the flap. You just have to make an incision in the cornea and remove a lenticule, that is called small incision lenticular extraction. So you can see more about the Lasik in my Numero Uno in Ophthalmology series, where you can get, if you just type Dr. Vineet Sehgal and you type the specific name of the topic that you want. So you just write Dr. Vineet Sehgal ROP, Dr. Vineet Sehgal keratoconus. So you would get the lecture details and the link. You can see the link and also you can get whatever you want. So you do not need to see the whole lecture in the Let's Crack NEET PG channel. In the ophthalmology list, you can basically see the playlist also. You can see whatever you want. So that is how the PG preparation goes. Do not see each and everything, see what you want. Okay, then this is a patient where you can see the Descemet membrane folds. If you can appreciate these stria in the cornea. So this corneal edema, you are seeing the cornea is having a more edematous structure and the DM folds. This can happen even after any intraocular surgery. So any intraocular surgery can have the Descemet membrane folds, and also remember that any intraocular surgery, what it can cause is it can cause decrease in the endothelial count. So if the endothelial count goes beyond certain limit, let's say less than 1500 millimeter, then there can be a corneal decompensation. Okay, then this is the next picture where you are seeing the cyst in the conjunctiva. So this is called inclusion cyst. The conjunctival cyst can be of many types. Sometimes it is just serous fluid based, which is called inclusion cyst. Sometimes it can be because of certain microorganisms, some certain parasites also. So you can have a cyst because of cysticercosis, you can have cyst because of dirophilaria, and sometimes you can have the cyst because of caterpillar hair also. So they can show you a picture and say that the caterpillar hair has caused this formation, what it is called. So remember the name, then the answer is ophthalmia nodosa, something which looks like a pingicula. Okay, chalo, let's move to the next question. So next question is, the image you are seeing, let's say a 20-year-old female came to the OPD with the redness of the eye. So with this, the patient is not having any watering or inflammation, but she is having a picture like this. So this is a subconjunctival hemorrhage. So subconjunctival hemorrhage, basically it can be post-traumatic, it can be idiopathic, it can be post any intraocular surgery, or the patients who are on, let's say, aspirin or warfarin, or hypertensive patient. The only thing which you have to remember is you do not need to treat the patients, it resolves on itself. Okay, resolves on itself, and there is no pain diminution of vision in these patients. This is basically a picture of subconjunctival hemorrhage. Okay, then you can have some pictures like this where you are seeing in the cornea and opacities like this. If you can appreciate in the picture, these are the subepithelial opacities. Okay, and these are called vortex keratopathy, whole keratopathy, or cornea verticillata. So some conditions like Fabry's disease or the drug deposits like my favorite amiodarone, phenothiazine, indomethacin, and chloroquine, they can cause a cornea verticillata. Like your other degenerations, cornea verticillata is also a reversible condition, and it also does not have any effect on the vision. Only thing is, when you are seeing the cornea verticillata, you need to know that there may be a drug toxicity, and you have to tell the physician to, if possible, can he decrease the drug dose or can he stop the medication. Okay, then this is also a condition which is called conjunctival melanosis. So if you can see around the cornea this black patch, so this is a melanin pigmentation around the conjunctiva. It is usually harmless, but you need to basically see that if it is not increasing, and if it increases, then you have to basically think about if there is no tumor or something fishy that is going inside. Okay, then they can give you a picture like this. Now see, this picture is not of a pingicula or pterygium because it is not basically affecting the cornea. See, the cornea is clear here. It is just outside the cornea. So this can be a patient of ocular surface squamous neoplasia. So remember, whenever we talk about the ocular surface squamous neoplasia, the final diagnosis has to be done after doing a biopsy. But definitely this is not a pterygium, this is not a pingicula. Remember, pingicula is slightly away a patch of the dryness, that is a patch of a nodule which is just away from the corneal limbus. This structure which you are seeing an elevated lesion, it is basically being supplied by the feeder vessels. Also, if you can see here, there are arborizing vessels, flower shaped vessels. So this can be a potential patient of ocular surface squamous neoplasia. But yes, definitely a pingicula, a inflamed pingicula, or a flectanular conjunctivitis, a flectanular nodular episcleritis can also look like this. So finally what you have to do is you have to remove the this nodule and send it for biopsy, and if you see the keratin pearls or the squamous neoplasia cells, then your diagnosis is confirmed. So they can give you a question like this, that this is the picture and the patient is responding to the topical mitomycin C therapy. So this is also an indication that patient is suffering from OSSM. Okay, then this is a patient who is having a microcornea. So whenever we talk about the microcornea means there is a small cornea and small eyeball. So you just remember it with the mnemonic MSS. So small cornea and small eyeball. Do not confuse it with nenophthalmos. In nenophthalmos, you may be having the small eyeball, but your cornea is normal and your lens is normal. Okay. Then this is a patient who is having a failed corneal transplant. You can see that this area, this is the host, this is the host cornea, and this is the donor cornea. You can see the host cornea is also getting a corneal haze, and you can see the vascularization there also in the host cornea. So a vascularization of the host cornea, this is a very important sign of a failing corneal transplant. So the hazy cornea and neovascularization of the cornea, they are basically telling you that this is a failed corneal transplant. Okay, then this is a picture of a intracorneal ring segment. Okay, I call it Intex, which is basically used in a progressive keratoconus. So these Intex are made up of polymethyl methacrylate not only they can help in the progressive keratoconus, they can decrease the total refractive power of the patient also. So those patients who have very high amount of the keratoconus, and these patients also are having a problem in their progression, they are progressing a lot. These patients are having a very good relief with the help of these intracorneal ring segments, which are called intakes. So thank you very much for attending this session. Hope you would have liked the session. We would be having few more sessions of the image based of questions in ophthalmology. Thank you very much. Subscribe for the channel Let's Crack NEET PG. If you have any doubts, you can ask me on the Telegram app. Thank you and Jai Hind.